Good morning and welcome to my lecture series. And we are dealing with the laparoscopic cholecystectomy in a patient with pulmonary hypertension. Induction of anesthesia was achieved with 250 microgram of fentanyl, 14 milligram etomidate and 40 milligram rocurium. Anesthesia was maintained with 1% isoflurane in oxygen and incremental dose of fentanyl. Initial ventilator settings were tidal volume 400 ml, PEEP 5 cm and rate 14 with a goal of maintaining an end-tidal CO2 of 30 mm mercury. The start of surgery with creation of the pneumoperitoneum, thereby restricting the lung expansion, and surgical stimulation producing pulmonary vasoconstriction was a time of potential instability. The surgeon agreed to use low insufflation pressure. Since laparoscopic cholecystectomy is performed in reverse tendinal mark position, tidal volumes were maintained with only a small increase in the airway pressure. PAPs were monitored with a plan for discontinuing the pneumoperitoneum and proceeding to an open procedure if there was evidence of decompensation. The ratio of pulmonary to systemic artery pressure was monitored as an index of stability. Surgical stimulation increased PAP, that is pulmonary arterial pressure, but did not change the ratio, allowing the deepening of the anesthetic with additional fentanyl. Cardiac output measurements confirmed the stability. During the case, the ventilator rate was progressively increased in 24 hours in respect to carbon dioxide absorption from the pneumoperitoneum. Volume status was monitored by TEE, focusing on both the right and left ventricle, and by CVP in addition to estimated blood loss. Management of emergence from anesthesia is often most challenging problem. Hemodynamic instability depends on the ratio of pulmonary to systemic vascular tone. Extubation in a light plane of anesthesia can produce pulmonary vasoconstriction, but extubation in a deep plane of anesthesia can produce inadequate ventilation. Pulmonary hemodynamics were monitored during emergence following optimization of narcotic administration, and a lidocaine bolus. If the patient had developed increased pH, that is pulmonary hypertension, and systemic hypotension, the plan was for high dose narcotics with transfer to the ICU for slow weaning. Although the pulmonary arterial pressure increased during the emergence, systemic blood pressure also increased with no change in the ratio of pulmonary or to systemic pressures. So, nitroglycerin was used for transient treatment of hypertension. Treatment of perioperative hypotension. Hemodynamic management in pulmonary hypertension should maintain blood pressure and cardiac output and minimize the pulmonary vascular resistance. When the cardiac output is low, vasodilator agents such as dobutamine, milneuron can increase the cardiac output and decrease the PVR. Systemic hypertension should be aggressively treated since it decreases the right ventricular myocardial perfusion, producing ischemia, and decreases the contribution of the interventricular septum to right ventricular cardiac output. Systemic hypertension may result from 4 etiologies, each with a specific hemodynamic pattern that can be diagnosed by pulmonary artery catheterization. Decreased preload is the only etiology with decreased CVP. Volume therapy is indicated but must be monitored since excess volume in a patient with a failing right ventricle may result in further distension and dysfunction. Decreased contractility increases the CVP but not the pulmonary arterial pressure. Inotropic therapy is indicated. When decreased systemic blood pressure occurs without a decrease in the pulmonary arterial pressure, the ratio of PVR to SVR has increased. The initial approach should be to reverse the correctable causes of increased PVR such as hypoxia, hypercarbia, and acidosis. In patients with hypertension but maintained cardiac output, decreased systemic vascular resistance can be treated by the systemic vasoconstriction with phenylephrine or vasopressin. A combined inotropic vasopressor agent such as epinephrine or norepinephrine may also be useful. When the exacerbation of pulmonary hypertension results in systemic hypotension and decreased cardiac output, inhaled pulmonary vasodilator such as nitric oxides or inhaled prostacyclin may produce selective pulmonary vasodilatation. A trial of 20 parts per million, that is 20 ppm, inhaled nitric oxide is sufficient to determine if the patient will have a beneficial response. Inhibition of cyclic guanosine monophosphate phosphodiesterase with sildenafil can increase the response to inhaled nitric oxide but may itself produce systemic hypotension. Although the drugs with combined inotropic and pulmonary vasodilatation effects such as Ctomy and milrinone can increase the cardiac output in patients with PH, their systemic vasodilator effects frequently contraindicate their use in patients with pulmonary hypertension-induced systemic hypotension. The patient never developed hypotension, this patient, but inhaled nitric oxide was available if needed in the operating room and the ICU. Postoperative management. Although the intraoperative management of PH is challenging, most patients who die in the perioperative period do so several days after surgery. Causes of death include progression, increases in the PVR, progressive decreases in the cardiac function, and sudden death. Patients should be monitored at least overnight in the ICU. Use of epidural narcotics and local anesthetics, continuous regional anesthesia, and non-narcotic analgesic adjuvants should be considered. The patient was monitored in the ICU overnight after surgery with continuation of her prostacyclin infusion and oral sildenafil. She was discharged home 2 days later and has subsequently done well. Okay, we now come to the end of my lecture series. I will come again with more materials in my next video lecture session. Thank you.